So good evening, everyone. Good evening from Manchester. Thank you very much indeed, Walid, for inviting me again to meet the audience and the esteemed panel through the Saving Lives Academy. Before starting, actually, I'd like to congratulate you on last week's amazing course, the updates in critical care ultrasound. Unfortunately, I was working, so I didn't have the chance to attend, but the feedback is amazing. So congratulations on that and keep up the nice work. I'd like to thank again Dr. Zaghloul for his amazing lecture, and actually both topics, enhanced recovery and day case surgery, are quite interlinked actually, and both of them aim at certain thing, which is increasing efficiency and decreasing cost in healthcare practice. First of all, to set rules, I'm not here tonight to patronize anyone and tell him how to anesthetize for day case surgery. And all my aim joining through Saving Life Academy was to try actually to transfer the UK experience that I had and try to work out with you guys a way of replicating this in your workplaces. In other words, how to develop successful day case service in your workplaces rather than telling you specifically how you would anesthetize for day surgery. So first of all, I'm Mahmoud Alkholany. I'm working as a trainee in northwest of England in the lovely city of Manchester within the national training program, close to finishing my training in 1 month or so. And my special interest is pain medicine and anesthesia. I promise, like I said, I'll be a light guest tonight talking about a light topic, yet a very important one, which is day case surgery. So let's start our lecture for tonight. First of all, conflicts of interest. I have none to declare here at all. Then objectives of my lecture tonight. So first of all, I'm gonna give you guys a little bit of overview of how day case services run within UK. It's something really very important, and we'll know over the coming few slides how hospitals get paid based on their achievement of the day case objectives within their workload. Then we're going to talk about a setup model that you can replicate in your workplace for delivery of day case. Then we're going to touch base quickly on the conduct of anesthesia for that group of patients. Then we'll discuss a little bit of the obvious reasons why such pathways might fail and the patients end up needing to be admitted to hospital in order to be looked after surgery. And then, of course, no pathway could succeed without a little bit of scrutinizing, data collection, and governance in order to be able to pick up the flows in practice and improve these consistently. So first, to start with, what day case surgery entails. What is it exactly? And actually, there is a difference between the US definition and the UK definition. So here in UK, you bring a patient for a planned intervention, surgery, procedure. You do the procedure and you discharge them home during the same day. And if for anyone who worked before in UK, they will know well that most of the day case units are closed out of hours. So after 5 o'clock, you won't find a day case unit operating. So you have to send your patients home by then from your day case unit. While in the United States, I haven't worked there before, but maybe because of the setup of the healthcare system. So the definition of day case is 23 hours. So your patient can stay till later in the hospital and then be discharged. But that doesn't apply to the practice in UK, where most of the day case units are closed out of hours. What's the history of day case and the focus of day case in UK? So actually, you will be surprised to know that the whole story didn't start very long time ago. For those who might think that there is big discrepancy in practice, you're not too late, and you can catch up with what they are doing actually if you're looking forward to developing this in your workplace. So the focus started more back in 2000, where the NHS plan for the future actually tried to focus on increasing the rate of day case operations and reaching arbitrary figure of 75% of cases to be done as day case. This was then followed by another document that came out from the Department of Health in the year 2004 that's aiming at modernizing the practice within the NHS in general. And what they said actually is all cases should be treated as if they are a day case in case they are elective. And I think similar thing applies to enhanced care. So enhanced care at a certain point gained popularity and was very fashionable talking about it. It started mainly in colorectal surgery and then started spreading to joint surgery. And like what Dr. Zaghloul explained tonight about neuroanesthesia and even in cardiac anesthesia. And now we realize that enhanced recovery is giving a good anesthetic with good outcome in order to be able to discharge your patient from hospital as soon as possible. And day case is the finesse of that process in order to give the best anesthetics that will allow you to be confident to send your patient home at the end of the day. So it's not actually a long thing that happened many years ago. It's within the couple of decades, past decades, and you're not too late to catch up. So why all this fuss about day case surgery? Why are we bothered about day case surgery? Why don't we leave all patients in hospital without any problems? And that's for obvious reasons, actually. Some of them are related to organizations, especially if you're working in a state-funded healthcare system or the payment comes from insurance companies. It's less cost, essentially. You don't have to run hospital bed post-operative that's looked after by a lot of professionals and has running cost that's high and high quality healthcare. So you send patients home in order to cut down any unnecessary cost. You will be able to use your resources because those hospital beds can be made available for any elective patients that need inpatient admission. And also, we've been hit hard by this in UK. I'm not sure how things are elsewhere. During the first wave, because we had to stop all the elective cases. So we are now dealing with unprecedented waiting lists up to the extent that we are using private hospitals now in order to go through all the pending elective work. So when you have more day case surgery, this means you can go through your waiting lists and minimize your waiting lists. And that's another factor, quality indicator, which actually brings tariff and brings money to hospitals here in UK, going through the waiting lists and not hitting the limit for patients waiting. And of course, patient, who is the center of our care. So there are benefits to day case to our patients. Evidence says that patients are more satisfied when they can go to their usual environment after having surgery. Here in UK, we collect what we call patient-related outcome measures, and it's always positive feedback about being able to go home after having surgery. And evidence told us as well that it helps patients to regain function quicker, and that even becomes more important in the elderly group of patients. And Dr. Zaghloul elaborated on postoperative delirium and cognitive dysfunction, and being able to send your patients to their usual environment is one of the most important factors in order to be able to prevent this from happening postoperatively. And of course, we can't flip this slide without talking about COVID. And like I said, we've been hit hard by that here in UK, maybe elsewhere, people among the audience can tell us their experience. And having successful day case in place is really very important in order to avoid unnecessary waiting and patients not having their procedures. And to be honest with you, while I was preparing this lecture, because I know well that Egypt, which is my country of origin, is not too behind in that we have actually in Egypt dedicated day case hospitals. But when I went on to search, unfortunately, I didn't find database. And all I found were news about transforming those facilities into isolation hospitals, which I can understand why this has happened. But it's sad, actually, because those places should have been used in order to go through all elective cases and make the best use of them during a pandemic, rather than transforming them into isolation hospitals. And again, I didn't find information or database which can help me to compare the practice, and it will be actually very, very helpful if any of the audience works in such kind of facility and gives us their opinion or their experience about day case surgery in, I would say, a less resourceful setup of work like Egypt or some of the other Middle Eastern countries. So how then to set up a service for day case surgery? While I was thinking about this lecture, I put down this this quote actually, what I thought is a successful day surgery is not only about how you're going to give your patients anesthetics. It's more about how you coordinate, how you work in teams, and how you plan forward for your patients, as we're going to see in the coming few slides. And that's actually the cornerstone of a successful day case surgery service. And one of the very important things actually is to try to find guidance. You're not going to invent the bicycle. You know, the guidance is there. Either American or North American, or coming from Europe or coming from UK. All you need to do actually is to search and see what suits you best and try to replicate it in your workplace. Here in UK, we have a lot of guidance. We have something called the British Association for Day Case Surgery. This association actually has loads of publications which any of you interested in developing such kind of service in your workplace can use and replicate. Surprisingly, actually, they have very huge list of cases that are recommended to happen on day case basis, up to more than 200. And I think the list is going to even expand more. And this includes different areas of anesthetic and surgical practice. One of the very valuable pieces of evidence that I would refer you to as well is the National Day Surgery Delivery Pack. And that's actually a collaboration between very important organizations here in UK. The first one is Get It Right First Time. And it's an initiative that started in one of the London hospitals. And its aim was essentially to minimize the discrepancy in the quality of care and standard of care across the board in all hospitals in UK. And then its work expanded to different areas, including standardization of day case practice, along with the British Association for Day Case Surgery and the Center of Perioperative Care. And the most important part of this pack, actually, that I'd like to refer you to is the appendix of this pack. It's about 32 pages, but includes amazing pathways for how to have successful day case pathways and recommendations from hospitals who are excelling in that area of practice across the country. Of course, when we are talking about guidance, this can be done without mentioning the Association of Anaesthetists, and they updated their guidance in 2019 for the provision of day case surgery. You can find it for free on their website, and there is simple infograph as guidance for people who are interested in the provision of day case surgery, which again is the collaboration of different organizations. The Royal College of Anaesthetists, who's supposed to be policing the quality of practice and the technicalities of practice across UK, has what we call the guidance for practice, and it covers different areas of practice and qualifies hospitals if they are following those guidelines to be accredited in terms of their services. And that is another factor that gauges their quality of practice and encourages the government, because like I said, it's a state-funded practice, to give them money to fund their practices based on their best practice and achieving the objectives in day case surgery. So as you can see, loads of guidance, None of them has been very old. A lot of them are new. So rest reassured, you're not too late if you don't have such kind of facility within your workplace. All of those guidance have commonalities among them, like what we're gonna mention in the coming few slides. And that's all in place to support the success of the day case pathway and minimize any sort of discrepancy in the provision of that service across the board here in UK. So what are the salient points actually that we can extrapolate from this guidance and use them and replicate them in our workplaces? First of all, organization of the day case service. In order to have a successful service in your workplace, you have to work out written protocols and guidance, which cover the different aspects of the day case service, starting from when you select and pre-assess your patients for appropriateness for day case surgery, how you admit them, which ward you're going to admit them in, how you conduct the surgery and the anesthetics, and then the recovery period till you send them home and you follow them up post-operatively. And that's actually where some hospitals are excelling compared to others, and there is a lot of development that's ongoing. Patient selection is very important. Here in UK, especially in an area like day case, we use a lot of specialist nurse input in the preoperative assessment of those patients and in nurse care led discharge and follow-up as well. During the process of selection, there are important factors that you have to consider in order to ensure success of your day case pathway. First of all, the social factors of patients. It doesn't make sense to call a patient from a city that's far away to come to your hospital to have a day case procedure, and then they struggle to go back to the city. So transportation, it has to be easy access and easy leaving of the hospital, and easy access again if a complication happens and the patient needs to be referred to the hospital. You have to make sure that there is enough support in place. Maybe you are a little bit privileged here in UK that you can organize some sort of care for the patient, not from the family, like care from the government or for the hospital to look after the patient in the 24 to 48 hours post-operatively. This might not be feasible in other places, but at least make sure that the social circle can offer enough support for patient post-operatively after discharge from hospital. And one of the very important things, and actually there is area of myth here when we are talking about the medical condition of patient, when some practitioners might think that if you have a chronic illness, if you're elderly, if you're obese, like what we're going to discuss later, you're not fit for day case surgery. And that's absolutely incorrect. It all depends on whether you have a medical condition that's controlled or not. That's what's going to preclude having a day case surgery rather than mere having a condition or a chronic condition. Most of that guidance that we talked about, if you go through them, all of them recommend having a dedicated unit for day case surgery in order not to have the inevitable mix between the inpatient and the day case, which unfortunately might end up affecting badly or negatively the provision of day case surgery. And they dictate as well having leadership. So you have to have a clinical lead, you have to have a clinician interested in that area and able to scrutinize it, police it, and develop it all the time. And similar thing for a matron and a nurse leader that's looking after this service in order to be able to ensure success. And again, we cannot go through this slide without focusing on training. And by talking about training, it's both the medical teams and the nursing staff. For those familiar with the environment of practice here in UK, and the training program, it does have a curriculum, and you cannot actually, and we call it spiral training, where you go through different subspecialties at different stages of your training, and you cannot actually progress through your training without having the module of the day case anesthesia being signed off in your training. Similar thing could be adopted in all sorts of certificates offered in Egypt, the Egyptian fellowship, or the master's and MD degrees offered by different universities, in order to ensure that people are well trained in that very important, cost-effective practice of day case surgery. Also, the nursing stuff, like I said, here in UK, we do have this option of specialist nurse who's trained in certain area and she can run it independently. And we use those specialist nurses in the preoperative assessment of the patients. They have access, easy access to clinicians if they need support or second opinion. And the discharge is nurse-led and the follow-up as well is nurse-led unless a clinician is needed. So that's as regard organization. What else can we draw from all the guidance that I've mentioned before? Like I said, dedicated facility, avoid mixing between inpatient cases and the day case patients. If you don't have this facility of having a dedicated unit, make sure that you have 1 or 2 theaters that can run as day case along your theater block. One of the problems that happen with day case is the fact that people think that you have to relax your standards, but that's not true. If you want to succeed with your pathway and if you want to be safe, you have to follow the standardized practice in terms of monitoring, in terms of equipment, in terms of availability of standard equipment like cardiac arrest and difficult airway, trolleys, etc. in your workplace. And these have to be audited, revised, restocked, and up to speed all the time in case you need to use them within your day case facility in order to ensure success. Staffing is of utmost importance, and most of the guidance that we mentioned before recommend that it should be a consultant-led service, or at least a senior person, like a senior trainee or a senior career grade doctor, in order to ensure success of this pathway. You don't send your most junior person in order to anesthetize the day case hernia or the day case whatever operation, breast surgery or orthopedic surgery. It's important to train them, and it's a good area for training for that group of doctors, but they have to be supervised by a senior clinician in order to make sure that everything happens as it should be in order to ensure success. Here in UK, for example, if an unplanned admission happens through the day case procedure, hospitals get penalized and they don't get their payment. So that's very important to be led by senior people. We focused and we talked about training in the previous slides. So that's very, very important area in all sorts of training programs of different descriptions within your working environment, making sure that you train your junior doctors and you train your nursing staff on the skills of providing that sort of service. And of course, having enough staff to man that sort of service successfully. How to conduct anesthesia? Like I said, I'm not here to patronize anyone and tell you guys how to anesthetize a patient. It's essentially giving a good anesthetic, balanced anesthetic with short-acting medications. Even if you give a spinal, nowadays the ambulatory, they call it ambulatory spinal or day case spinal, is something that you can offer using agents like 2-chloroprocaine or prelocaine in short procedures, and then you send your patients later. Or even some clinicians might use things like heavy bupivacaine, and they accept the degree of residual weakness and they send the patients with clear instructions. But what's more important than the specific medications or the specific techniques that you're going to use for your anesthetics is to select your patients appropriately. So those patients cannot happen by chance. You have to assess them in advance and make sure that they are fit enough to go through a day case pathway successfully. And by saying that, it's not about medical problems or having chronic medical problems. It's about optimizing these beforehand and making sure that the patient is ready on day of surgery to have a day case procedure. One of the things that helps success is minimizing starvation. Unfortunately, a lot of clinicians don't give clear instructions to their patients, and they end up coming fasting like 12 hours plus before surgery. They will come dehydrated, thirsty. This increases the risk of postoperative nausea and vomiting, which is one of the major factors of failure of day case, as we're going to mention next. So allow them to drink. Some hospitals, and that's actually endorsed, allow them to have tea and coffee and water up to the time of surgery. So be on the safe side because of the culture of your patients who might not abide by your instructions or misinterpret them. At least allow them up to 2 hours of fluids, clear fluids, before time of surgery to counteract dehydration, which has a deleterious effect on the success of your pathway. Postoperative nausea and vomiting is very important. There are loads of calculators and risk stratification tools. Use them. Take history from your patient and see what sort of operation are they going to have and whether this increases the risk of postoperative nausea and vomiting, and be proactive by using a multimodal antiemetic approach, and maybe even, like Dr. Yasser explained in his lecture, using things like propofol, which has an antiemetic effect that might minimize the risk of postoperative nausea and vomiting as part of total intravenous anesthesia. And of course, optimize the analgesia of your patients by using a multimodal approach and sending them away with take-home medications, which can control their pain with easy access to the hospital to ask for advice if they need to. Postoperatively, for those patients, again, you have to have well-written protocols and pathways for the discharge of that group of patients, which should be nurse-led. So you have to have your trained nurses who can do that. We talked about the social circles, so you have to make sure that your patient is supported in their community and someone will be able to stay with them and look after them post-operatively. You have to signpost them to how to reach the hospital, either by telephone or physically, if they have any sort of complications, in order to feel safe and confident to undergo a day case procedure. And I can't stress more on the importance of having leaflets and brochures and giving them to your patients beforehand during the preoperative assessment, in order to be able to tailor their expectations and educate them before they hit the hospital and go through the day case pathway. Your patients actually are an important factor in the success of those pathways to invest in. So you have to educate them, talk to your patients, tailor their expectations, let them know in advance what to expect when they come to the hospital to have a day case procedure. Like I said, signpost them to points of contact and reassure them that they are going to automatically be followed up next day after day case surgery, and provide them with enough resources of information to give them the confidence of going through this pathway. And then, like I said earlier, you can't actually ensure the success of such kind of pathway without scrutinizing it and looking into it and following up the information and the data and collecting outcomes for your patients. So you have to have a system in place, system of governance to audit what's happening in your unit, have quarterly reports, look into them, reflect on them, and see what needs to be improved, and conduct your quality improvement projects to continuously improve the quality of practice within your day case service or day case units. And most importantly, looking into reasons for failure to avoid them and collecting outcomes from patients, including their satisfaction with your service. Some of the areas of controversies, or I would say myth, that people think about day case surgery. So they think that higher grade ASAs are not fit for day case surgery, which is not true. You can have a patient who's well controlled. It's better for him or her to have surgery and go back home afterwards. So the mere ASA grade is not a contraindication. But of course, if you have a patient that's not controlled with a decompensated organ failure, like heart failure or active pulmonary disease, it doesn't make sense at all to put them on a day case list. They need perioperative optimization and looking after them postoperatively. But it's not just what ASA grade they are, it's whether they are controlled or not, whether their disease is active or not, and risk versus benefit assessment of each patient individually. Obesity, a lot of people think that if I have an obese patient, I'm gonna admit them intraoperatively, which is not true. By educating your patients, assessing them, screening them for things like obstructive sleep apnea, and if they are on CPAP for that, ask them to bring the CPAP with them for the postoperative period, and you educate them what to do afterwards, and you tailor your anesthetics in order not to compromise their breathing afterwards, and they still can have successful day case surgery. Elderly patients, unlike what a lot of people would think, that group of patients actually benefits most from going back to their usual environment. Otherwise, they become prone to medicalizing them unnecessarily within the hospital, and they are at risk of unfamiliar environment and the risk of developing delirium and postoperative cognitive dysfunction. And in the practice of day case orthopedic surgery, they found out that that group of patients, they lose muscle strength and function postoperatively because they are dependent on the nursing staff helping them, even if they are visited by physiotherapy, but they still do not regain as quickly as it should be their independence by being in their environment, mobilizing with their homes or flats or whatever. The other group of patients are pediatric patients. Again, there is no contraindication. It's a group that would benefit from going back home within their community, within the care of their carers and parents. There are maybe certain groups that you have to be careful, like neonates. If you have an infant that is preterm, less than 60 weeks conceptual age, again, it's not right to do their operation as day case because they are risk of apneic spills, and you cannot send them unmonitored home. Kids with obstructive sleep apnea, especially those coming for tonsillectomies, again, most probably you will have to admit them to keep an eye on their breathing post-operative rather than sending them home and having complications. So there isn't actually a massive contraindication in that group of patients. On the contrary, they benefit most from day case pathways if you just bear in mind those groups that you have to be careful with. So we talked about, a little bit of idea about the practice and the history of day case in UK. What sort of guidance is available from different professional bodies to govern the practice of day case surgery. We touched base actually on how this is something very important here in UK, where hospitals actually get paid on some quality indicators. One of them actually is the practice of day case and the success of day case. And now we're gonna shed little light on what might make it fail, why patients coming for day case surgery might end up being admitted to hospital rather than being sent home. And there are multiple factors actually. The most important are poor selection from the outset and optimization of your patients. You have to be careful. You have to cherry pick them in order to make sure that they are gonna succeed within that pathway. One of the major things as well that might lead to failure is postoperative nausea and vomiting. And you have to risk stratify your patients, ask them about history, see what sort of surgery they are having. You might want to opt for regional anesthetics if that's feasible rather than GA. And if you opt for GA, you might need to opt for TEVA rather than volatile-based anesthetics and minimize the use of your opiates in order to minimize the risk of postoperative nausea and vomiting, and use multimodal antiemetics along with minimization of the starvation and dehydration before surgery. Poorly treated pain is another reason for failure. And you have to have a multimodal approach to the management of pain in those patients and have clear stepwise protocols using the WHO ladder or whatever protocol in your hospital to help the nurses to deal with the pain of those patients in the post-operative periods. Of course, intuitively, there might be unforeseen complications, surgical or anesthetic, but that's inevitable. You will have to admit your patients to hospital. And always, despite the fact that we are focusing on the fact that we need to make it succeed, we need to send our patients home, but don't feel ashamed at all if it fails, and never put the safety of your patients at risk just because you'd like to be in the eyes of your managers and eyes of your bosses that you're doing a successful job by sending patients home, because the worst thing you want to have is a patient presenting with major complication back again to hospital after a day case surgery. So what's our take-home message from today? Again, I wrote this while preparing the lecture. So I think day case surgery, which a lot of people take lightly, reflects actually the level of finesse in the delivery of anesthesia, for the very simple reason, because after delivering our anesthetic drugs, most of which are toxins, you feel confident that your patient is safe enough to be sent home. So it needs actually a lot of work, a lot of investment in facility, premises, and human as well, doctors and nurses, in order to reach this stage of finesse. And that concludes my lecture. Thank you very much.
Thank you, Dr. Mahmoud, for this highly informative illustrations about day stay surgery. And I think the most problem we face in is the organization of this service. And second, it's easy, as you has just said, it's easy to understand what's the anesthesia monitoring and so on. And just you mentioned the service in Egypt as an organization service, I admit it is not well conducted. But on private basis, I can see that nowadays, due to advancement in anesthesia techniques and local blocks and easily recovered anesthesia, as SIVO and propofol, I can say that most cases now are day stay surgery, but on private basis, individual private basis.
Yeah.
Any question from the audience? Only one question. Thank you for your wonderful lecture. Can regional anesthesia technique be used in day stay surgery?
The answer is yes, of course. If you give clear instructions to your patients, so for instance, if you're coming to do a hand surgery and you do it under axillary and supraclavicular block, that's totally acceptable. And if you give clear instructions for your patients about the heaviness of their hands, of their upper limb, and how to protect it, that's totally acceptable. Similar thing for even spinal. So medications like prilocaine and 2-chloroprocaine, which is regaining turf in the anesthetic practice, you can use them and give your patients day case ambulatory spinal and send them home at the end of the day, or even accept the degree of residual weakness and sensory loss before sending them home and following them up on the night and second day after surgery. So regional anesthesia is 100% acceptable as a practice for day case surgery.
I'm just laughing this because things are a little bit changes. I had this question in my MSc 35 years ago, and that time spinal and epidural was not considered as method of anesthesia in day stay surgery.
I would agree with epidural. Definitely, I would agree with epidural. Yes. I won't send someone with epidural unless it's like for pain management purpose and under very, very strict circumstances. An end-of-life patient was not fit for anything invasive, like doing an invasive neurolytic procedure or intrathecal pump, and their expected death is very close. And they want to die at home. most probably that's the only occasion where I'm going to send someone with epidural to home. But in the context of fit, healthy, that's having surgery and going to go home, I would be really skeptical about that, because that's recipe for problems. But spinal, I think it's totally acceptable to do it and then send patients home later, especially with short-acting hyperbaric spinal agents.
May I add something here, Dr. Magdi?
Walid,
Magdi, if you allow me,
another
just
question. Another question.
No. Yeah. I just need to confirm with Dr. Mahmoud, is that regional anesthesia or spinal anesthesia excluding in the day surgery long-acting narcotics like morphine, or you still can use spinal morphine in day case surgery?
Well, most probably in spinal, most probably you're gonna avoid it. So you're gonna use plain spinal, and then you send them home with backup analgesia after the spinal wears off. So you're gonna avoid using spinal, because most probably it will be a short surgery, so you don't need the benefit of prolonged effect of putting opiates with them, and you can send them with backup analgesia home.
Perfect. Thanks, and sorry for interruption.
I think you raised the same question. Is it safe to use long-acting opioids in day-stay surgery?
It's not a no-no. So if the patient is in pain, you might have like a chronic pain patient established on loads of opiates before coming to you. And maybe that's a reason why they are going to fail to go through a day case pathway. But it's not a no-no if you use it judiciously. And you monitor your patient, and you start with a small dose, and you search for other reasons why this patient is still in pain. It's not an absolute contraindication to give long-acting opiates, but you have to be careful. So it's an individualized approach and individualized practice for your patients.
Thanks a lot. I think now it is in the Gulf area. It is beyond midnight. And in Western area, it is a little bit earlier. So thank you, goodbye. So goodbye, wishing to see you again. Thank you.
Thank you very much.
Thank you.
Thanks so much. Have a good night.
And thank you, Dr. Zahloul. Nice to be with you tonight.
Thanks very much. Thank you.
Thank you.
شكرا محمود.
Thank you very much. Thank you, Dr. Zahloul.